Hi, welcome everyone to this really interesting webinar we have for the next hour. So my name's Mervyn Singer. I'm in a very sunny London in the UK, so I'm bathed in the beautiful sunshine, and it's my pleasure to moderate this session. So we have two lovely speakers who will talk about the role of beta blockers in the intensive care, both the pros and the cons side. And without further ado, because I'm sure you'd rather hear them than me, we'll start off with our first speaker, who is Vasilis Papayonoi. I probably pronounced that badly. Thank you very much indeed. Yeah, Greek's not my best language, I'm afraid, apart from Efaristou. He's Professor of Critical Care and Computational Medicine at the Democritus University of Thrace in Greece, and he'll take us for the next 20 minutes on a journey through sepsis-induced cardiomyopathy. So he'll talk about mechanisms and the rationale for giving beta blockers. Vasilis, over to you. Thank you.
Well, Mervyn, thank you very much. Good afternoon, everybody, all our viewers. I would like to thank the European Society of Intensive Care Medicine and ALP for this invitation. And the question mark you can see is actually referring to the question if we should beta stimulate or beta blockade the septic heart. And this would be the topic of my next presentation within the next 20-25 minutes. These are my conflicts of interest within the last 2 years. Well, cardiac failure and sepsis includes both left ventricular systolic and diastolic dysfunction. According to many different experimental studies, approximately 50 to 60% of septic patients can develop this kind of systolic dysfunction, which is afterload sensitive. And what is really important is that it does not increase LV filling pressure. Diastolic dysfunction can occur in up to 50% of patients, and it's an independent predictor of mortality and can be associated with LV relaxation impairment or maybe a slight LV dilatation. And finally, we have RV systolic dysfunction, which can be isolated or associated with ARDS and subsequent increased pulmonary vascular resistance. This is the classic study by Parker and colleagues published in 1984, where you can see there's a reduction of the ejection fraction of the left ventricle during the first 3 to 4 days upon onset of septic shock with subsequent normalization. But what is really important in this study is that non-survivors exhibited high ejection fraction in relation with survivors. And 1 year later, Parillo made his classical experiment where he showed that after incubating cardiac myocytes with serum from septic shock patients, he noticed that there was a significantly decreased extent of shortening as well as velocity of contraction, meaning that in the blood there was a kind of factor that was circulating that decreased contractility of the left ventricle. And subsequently, after a few years and many studies, this was found to be human necrosis factor alpha. Don Baron from France in 2003 studied 183 patients and found that approximately 1/3 of patients, there was a kind of hypokinetic profile, meaning low left ventricular ejection fraction was associated with low cardiac index. Nevertheless, patients who exhibited a normal or high ejection fraction exhibited both a high and low cardiac index. So there was not any kind of correlation between normal and or high left ventricular ejection fraction and cardiac index. And after subsequently analyzing his data in this classic, in my view, diagram, he showed that patients who exhibited both increased cardiac index and left ventricular ejection fraction, the so-called hyperkinetic profile, had actually the worst outcome. They were suffering from persistent vasoplegia and had decreased LV intrinsic contractility. So this high cardiac index and this high ejection fraction does not mean that our patient is fine. It means that there's a huge vasoparalysis, reduced left ventricular afterload, and this is associated with this kind of hyperkinetic profile. And this picture shows us very nicely that patient with a hyperkinetic profile with an ejection fraction of approximately 70%, upon administration of noradrenaline or norepinephrine, if you prefer, during septic shock for restoration of blood pressure, his EF, LVF was reduced to approximately 40%, meaning that administration of vasopressors can unmask this reduced contractility and reduces ejection fraction in this kind of patients. And how can we actually understand these inconsistencies? As you can see, we have to understand that if you see the math, ejection fraction of left ventricle actually depends on the ratio between end systolic and arterial elastance. And what are these kind of elastances? As you can see on the PV loops on the left, this is the pressure volume loop of the left ventricle. There are two lines. The first line connects end diastolic volume with the end of the ejection phase, and this is the arterial elastance. which is a lumped parameter of arterial load, of arterial afterload. The other line is the end-systolic elastance, or ESPVR, which connects the unstressed volume of the left ventricle with the end of the ejection phase. And these two lines have a ratio which means to be around 1. This is the so-called ventricular arterial coupling, and it actually reflects the mechanical efficiency of the contraction of the left ventricle. As you can see from the question down on the left, this mechanical efficiency is actually the ratio of the blue area divided by the sum of blue and pink area, and means the oxygen consumption of the heart in order to eject a particular stroke volume. So in cases of that this ratio is altered, theoretically, if the ratio of arterial to end-systolic elastance is higher than 1.36, we're talking about ventricular arterial uncoupling. And what does this mean? It can mean either an increased arterial elastance or a decreased end-systolic elastance. End-systolic elastance can be decreased when we have a reduced contractility of the left ventricle. Arterial elastance can increase when we have high sympathetic tone, high heart rate, or increased stiffness of the aorta. And we know from different studies, such as the study from Pincy's group, that sepsis per se can increase stiffness of the aorta, can increase arterial elastance. And this has been attributed to a reduced bioavailability of NO. Sympathetic tone can also increase arterial elastance, as Manuel Garcia has shown us, that the progressively increased doses of noradrenaline can actually increase the return of different reflected waves from the periphery, and this can increase pulse pressure, arterial elastance. Increased heart rate can increase also arterial elastance. And this is due to the fact that during diastole, blood vessels will relax, but this relaxation is a time-dependent phenomenon, meaning when there is not a lot of time for diastole, there's not a lot of time for relaxation, and so vessels become more stiff just because of increased heart rate. So different mechanisms can increase arterial elastance, can decrease ventricular arterial coupling, and this means actually that the heart have to work harder, have to consume more oxygen, more energy in order to eject the same stroke volume. Mechanisms responsible for septic cardiomyopathy are extremely complex and interrelated. This is a classic paper from our moderator, Mervyn Singer, that shows that, first of all, we have a lot of free radical production, which can inhibit the effects of catecholamines per se. We have the downregulation of beta-agonists receptors. Beta-agonist receptors go into the cell, and they're not actually that much at the level of the cell, of the cellular membrane. So there's a kind of receptor where catecholamines will act. Sepsis can induce production of NO, which NO can, through cyclic GMP, decrease levels of cyclic MP, decrease subsequent phosphorylations that are obligatory, that are necessary for the cross bridging between actin and myosin. Also, we have alterations at the level of different ionic currents in the cardiac myocytes. Sepsis has been found in different experimental studies to inhibit L-type channel calcium-induced channels, which are responsible for the entry of calcium into the cell. It can inhibit ryanodine receptors which are located in the sarcoplasmatic reticulum and are responsible for the exit of this calcium from the SR into the cell. They can also decrease the re-entry of calcium during diastole into the sarcoplasmatic reticulum, and this is responsible for the diastolic dysfunction, which, as I said in the beginning, is an independent predictor of mortality. And finally, we can have alterations in terms of sensitivity of troponin to calcium, as Tavernier has shown. So there's not a lot of calcium binding to troponin, and subsequently reduced cross-bridging between actin and myosin. All these phenomena can induce a decreased contractility of the cardiac myocyte. Regarding therapy, we know that the mainstream of therapy in inflammatory vasodilatory shock is the administration of fluids, catecholamines, and vasopressors. And as our moderator again has very nice and wisely said, he has actually described this kind of schizophrenic Jekyll and Hyde properties of catecholamines during critical illness. And as he has said, we're stuck actually within the skill of compromised tissue perfusion in septic shock and the cardiac of the complications of currently recommended first-line treatment. And we know from many, many studies from both the experimental and clinical literature that catecholamines can increase oxygen consumption and metabolism, can increase clot stabilization, platelet activity, can reduce both innate and adaptive immunity, can increase bacterial virulence, and all these extreme complications. And in terms of immunomodulation, I'm showing you this diagram where you can see that both parts of the ANS have significant immunomodulatory effects. First of all, we have to keep in mind that our brain is monitoring the inflammatory status throughout the body. And the first mechanism, the fast-track mechanism of downregulation of this inflammation is the so-called cholinergic or anti-inflammatory system. by Kevin Tracy, who was the first who described it as an immunoreflex, where acetylcholine can act through particular nicotine receptors that exist at the level of macrophages and can suppress immediately the production of inflammatory cytokines. Nevertheless, the sympathetic system has dual effect upon immunomodulation. It can either suppress cytokine release through beta-2 adenine receptor or enhance cytokine and chemokine production through alpha-2 adenine receptor. Stress cardiomyopathy. Adrenaline and noradrenaline can increase irrespectively of our exogenous administration up to 100 times in septic shock. There is a kind of hyperadrenergic stimulation. And according to some studies, even 60% of patients can develop this kind of cardiomyopathy, stress cardiomyopathy, or Takotsubo cardiomyopathy, or apical ballooning syndrome. We know since decades that high level of catecholamine can destroy the histology of cardiac myocytes. It can induce the so-called contraction bud necrosis. Sepsis, as well as other stroke, for instance, so on, can induce this kind of particular contraction of the left ventricle, where you can see this hypercontractile base of the left heart and the hypocontractile apex of the left ventricle with inversion of the waves. This is called Takotsubo cardiomyopathy and can induce pulmonary edema and significant cardiogenic shock. What about catecholamines? Many studies, I'm just showing you the study by Martin, who show that doses up to 1 microgram per kilogram per minute of norepinephrine in septic shock patients is associated with high mortality of 90 days in relation with those who were needed less than 1 microgram per kilogram per minute of noradrenaline. And this is another study that was published in 2012 that showed in patients suffering from multiple organ dysfunction syndrome, it was I think 58 or 59 patients, that those who exhibited a heart rate higher than 90 beats per minute had significantly worse outcome in relation with those who had lower than 90 beats per minute. And as you can see on the right histogram, all non-survivors exhibited high heart rate in relation with survivors, but nevertheless, this difference reached statistical significance only during day 0, that it was the day of diagnosis of multiple organ dysfunction syndrome. I'm reminding you of the Microsoft study that was conducted in 36 ICUs around Europe that showed that only the combination of increased heart rate higher than 90 beats per minute in association with microcirculatory alterations increased mortality significantly than microcirculatory alterations alone or heart rate increase alone. So the question that arises is, do we need to beta stimulate the septic heart in order to improve tissue perfusion and subsequently delivery of oxygen to the tissues, or should we beta blockade in order to protect myocardium and decrease cellular oxygen needs? In this context, in this respect, the concept of decatecholaminization has arisen, which actually aims to attenuate, by the use of beta blockers, to attenuate the inflammatory cytokine production, to improve cardiac function through different mechanisms, to counteract all the metabolic dysregulation that is associated with this kind of hyperadrenergic crisis, to prevent negative consequences from sympathetic stimulation, and maybe to prevent dobutamine or not dobutamine arrhythmia that can occur, particularly in patients with decompensated heart failure and reduced ejection fraction. Berg was the first author in the late 60s who tried to evaluate the effect of beta blockers in septic shock dogs and found that the administration of propranolol was associated with a rapid restore of blood pressure, of hypotension, because as he showed, it was actually responsible for closing all these kind of arteriovenous shunts that were open during sepsis, as well as decreasing congestion within the lung and ameliorating all the VQ inequalities. Macea from Italy in 2012 conducted a pharmacoepidemiological study that included more than 10,000 patients, from whom 1,000 were septic, and found that patients who were under beta blocker before admission to the ICU exhibited significantly reduced 28-day mortalities, around 80% in relation with those who did not receive beta blockers before ICU admission. And why maybe beta blockers could favor patients under septic shock? Theoretically, beta blockers, through their negative inotropic effect, will decrease this ESPVR, this arterial and systolic elastance I was talking about. But due to the fact that it will induce a prolongation of the duration of diastole, maybe the stroke volume will finally increase. Moreover, as Andrea Morelli has shown with the administration of esmolol in septic shock patients, the decrease in heart rate will decrease this kind of stiffening I was talking about due to decreased diastole. So it will give time to the blood vessels to relax during diastole, and this will decrease arterial elastance, decreasing at the same time pulse pressure, as you can see on the arteriogram on the right. Immunomodulatory effects. This is a classic study that was published a few years earlier and was concerned about landiolol in an experimental model of sepsis that showed that the administration of landiolol was able to decrease levels of TNF-alpha, IL-6, and high mobility group OX1 protein, all are known pro-inflammatory mediators. And this decrease in this kind of cytokines was attributed to decreased binding of NF-kappa B, the so-called nuclear factor kappa B, which is responsible for the production of different cytokines through DNA stimulation of the genes responsible for the production of the cytokines. Also, beta blockers can upregulate beta-2 adenine receptors. You can see on the center of this slide, this histogram in HEC293 cells, that the administration of isoproterenol is the second bar, reduces the density of beta-2 adenine receptors, where at the same time the co-administration of different beta blockers restore this density. This is more nicely illustrated on figure C. In HL1 cells, green light corresponds to the density of beta-2 adenine receptors. You can see the reduction of their density upon isoproterenol administration and the partial restoration of their density upon administration of beta blockers. Another potential mechanism is the decrease in the apoptosis that is associated with high catecholamine effects upon the heart. Actually, we know that all catecholamines act through particular G proteins, and we have both GS, these G stimulatory proteins, and GI, G inhibitory proteins. So this study showed in cardiac myocytes that beta-1 selective blocker or beta-2 agonist can, through GI protein, decrease apoptosis, where the other mediator can increase apoptosis of cardiac myocytes, beta-2, beta-1 activation. In terms of histology, these are the classic studies by the group of Marcos Rossi and Mara Ruba-Selles from Brazil, who showed in a septic model in mice that what occurs actually in sepsis is a decrease in the expression of different connexin proteins, and connexins are responsible for the electric conductivity, the electric connection between cardiac myocytes. So it's the kind of uncoupling between cardiac myocytes, and these results have been confirmed in humans, in patients who died from septic shock, in post-mortem analysis by the Hodges group, who found that in septic cardiomyopathy, what was really happening was, apart from a slight injury at the level of mitochondria, there was a decreased expression of connexin, and they characterized septic cardiomyopathy as a kind of channelopathy. So different studies, as this one, if I pronounce properly, I apologize, I don't pronounce properly his name, found that the administration of beta-2 adenine receptor or beta-1 blocker was associated with increased expression of its connexin. And this means we will have a better conduction velocity in case of better electric coupling between cardiac myocytes and subsequently better contractility. We should not forget the case of dynamic left ventricular outflow tract obstruction. This is a study including more than 500 patients by Mr. Slama from Amiens, France, who found that approximately 22% of patients exhibited this kind of phenomenon. You see on the left the static LVOTO, left ventricular outflow tract obstruction, which characterizes mostly patients suffering from HOCM, from hypertrophic obstructive cardiomyopathy. But this phenomenon can occur in patients particularly suffering from hypertension or coronary artery disease, in case of a very hypercontractile and underfilled left ventricle. In this case, you can see there is a high velocity of the blood through the LVOT can pull the anterior leaflet of the mitral valve. This is called SAM, systolic arterial motion, through a Venturi effect. And this can induce a mid-systolic or late systolic closure of LVOT. Is this dagger-shaped pattern of flow you can see on the right. And this can induce a significant pressure gradient, even more than 50 milliliters per mercury, meaning that these patients will develop pulmonary edema upon beta stimulation. In this case, we need to give vasopressors and beta blockers. What about ANS dysfunction? We must remember that the more severe the patient, the more disturbed, the more impaired the function of the autonomic nervous system. Many studies have shown that. And autonomic nervous system has been found to be an independent predictor of mortality in septic shock patients. And why does this happen? It can happen either due to defect, increased apoptosis actually, of ANS nuclei at the level of CNS, or due to a reduced trafficking of the ANS input upon the heart. This is actually associated with loss of baroreflex sensitivity, or finally due to reduced responsiveness of cardiac myocytes, especially pacemaker cells, to different ANS inputs. And different experimental studies, mainly from Germany and Austria, have shown that endotoxin and different exotoxins as well, from both gram-negative and gram-positive bacteria, can affect the IF. IF, or funny current, is one of the basic mechanisms responsible for the automaticity of cardiac pacemaker cells. So what the studies have shown is that endotoxin can decrease significantly the responsiveness of cardiac pacemaker cells to vagal tone, and on the contrary, it can increase substantially the responsiveness to beta-2 to beta-1 stimulation. And we have the ability, using different algorithms, different softwares, real time at the bedside, to continuously measure ANS input upon the heart by mathematical analysis of heart rate signals and evaluating either baroreflex sensitivity or heart rate variability, that is the variability of the RR in heart rate time series. And if we decompose the signals into different frequency components, because every signal includes different frequencies within it, we can find the high frequency, it's the red line you can see on the left in this kind of fast Fourier transformation of the signal. And this high frequency corresponds to the vagal tone. And the low frequency, the yellow actually area, that corresponds mostly on sympathetic tone. So we can have real time the ratio of low frequency to high frequency components, which correspond to the sympathovagal balance. The white area, which corresponds to lower frequency, reflects mostly metabolic inputs upon cardiac myocytes. So different studies, as this one by Calvert from Germany, have shown that the patients with significantly worse outcome have decreased heart rate variability, particularly very low frequencies, and patients with increased heart rate have decreased complexity of their signals. You can see on the left, there's reduced noise, if you like, in relation with control patient, but this noise is not actually noise, it's this inherent property of a complex system to adapt to different stressful situations. And in another study by Carrara, it was shown that upon septic shock, T2, and after administration of fluids and vasopressors, T4 on the left histogram, there is a significant decrease in aortic compliance, as we have already said, as Pinsky has shown always. This decreased compliance is associated, if you see the box, the plot on the right, is associated with reduced baroreflex sensitivity, meaning that the higher the autonomic nervous system dysfunction, the lower the compliance of the aorta, and the lower the heart rate variability. This vicious cycle is associated with tachycardia that is not adaptive, but is maladaptive in septic shock patients. And we know from the cardiovascular literature that beta blockers can restore this kind of heart rate variability, either in patients suffering from acute myocardial infarction or in patients suffering from decompensated heart failure. And what about sepsis? There's only one study up till now in the literature, in experimental model of sepsis, that has shown that esmolol can also restore this kind of heart rate variability. On the right, you can see this blue and black line. The blue line corresponds to the administration of LPS plus beta blocker, and the black to LPS plus placebo. You can see that the administration of esmolol was associated with increased high frequency and decreased LF-HF ratio, meaning restoration of the autonomic nervous system balance in septic shock animals. And why do we care about that? Because as we and others have shown, continuously measuring heart rate variability is a kind of physiomarker that can reflect different biomarkers, such as pro-inflammatory cytokines. Many studies have shown that reduced heart rate variability is associated with increased IL-6, CRP, IL-8, and decreased IL-10. So we can have a surrogate marker continuously measured at the bedside of different balance between pro-inflammatory and anti-inflammatory cytokines. And if we assume that by increasing heart rate variability, we can decrease inflammatory cytokines, this can be attributed to different mechanisms. I suggest that this could be associated, for instance, with an activation of the immunoreflex, as you can see on the left. Reduced inflammatory cytokines are due to the high vagal tone upon the spleen. This is how immunoreflex works, where the splenic nerve actually, through beta-2 at the nerve cells, at the level of T cells, induces production of acetylcholine, which subsequently will suppress production of pro-inflammatory cytokines from macrophages in the spleen. Or, according to some other theories, the administration of beta blockers will increase motility of the large intestine, will preserve gut barrier function, and will decrease spillover of different cytokines. At this point of time, we're trying to recruit patients, septic patients, and evaluate the effect of landiolol versus esmolol upon heart rate variability, because we suggest that landiolol, due to its very more high cardioselectivity in terms of beta-1, beta-2 blocking, will have more significant effect upon heart rate variability recovery. And at the end, I just would like to present these results from the 1 year, actually was last year, that was published, systematic review meta-analysis, including 6 randomized controlled trials, Morelli studies included as well, that showed average risk reduction of approximately 80% and an average need to approximately 5 upon administration of ultra short-acting beta blockers, both esmolol and landiolol, in septic shock patients. So conclusions, to beta stimulate or to beta blockade the septic heart. I suggest that by using beta blockers in the septic ICU patient and controlling heart rate, this will maintain stroke volume, in most of the cases at least. It will reduce norepinephrine requirements and it will reduce arterial stiffening and ameliorate ventricular arterial coupling, meaning better efficiency of the ejection of the contraction of the left ventricle. And apart from those cardiovascular mechanisms, there are other potential immunomodulatory mechanisms, such as the anti-inflammatory effects that have been shown to be affected through reduction of the different cytokine levels, improving potentially gut barrier and motility, and reducing translocation of different cytokines or microbes, and finally improving autonomic nervous system balance through recovery of heart rate variability. Thank you very much for your time and your patience.
Lovely. Vasilios, thank you. That was a very, very elegant discussion on the sort of mechanistic and translational approaches to beta blockers. So thank you. What I forgot to say at my intro at the beginning was, please, audience, do put your questions, comments, thoughts on the eLives TV chat, and then I can then read them out and ask our lovely presenters to give their comments on your questions. So eLives TV chat, and then please type them in. Without further ado, delighted now to welcome Daniel De Backer, I'm sure very well known to everyone, an ex-president of the European Society, and he's a professor in the Free University in Brussels and in charge of the ICUs at the Chirac hospitals in Brussels and just outside. And he obviously lots of experience in sepsis circulation, and he'll talk about unexpected, I was asking him earlier, I think we've got expected and unexpected side effects of beta blockade in the critically ill patient. Daniel, many thanks indeed. Over to you.
So thank you very much, and good afternoon to all. And so indeed, we will rapidly jump on the aspect on what occurs indeed in sepsis, and perhaps the unexpected effects of beta blockers have already been shown by Vasilis, and we need indeed to discuss a little bit more on the hemodynamic side aspect, because of course the other inflammatory and modulation of different aspects have been well discussed, but when we expect some adverse effect, it will mostly be on the hemodynamic point of view. And so it's interesting to look at, again, at the experimental setting, and perhaps one of the most intriguing effect initially was to show that even though beta blockers were given to septic animals, the stroke volume was preserved in these animals. And so when you look into details, even though there is a significant decrease in the contractile force of the myocardium, the stroke volume was preserved. We say, okay, then this could be an improvement in the diastolic function. Well, it is not, because if you look also at the diastolic function, the minus dPdt is also impaired in septic conditions when beta blockers are given. So stroke volume is essentially maintained despite the impairment in contractile force, despite the impairment in diastolic function, because of the increase in diastolic time. So indeed, the heart rate control there seems to be a crucial aspect, but we need to pay attention to the fact that the contractility will be impaired, and also perhaps the diastolic function may be impaired, and what will be perhaps in some patients the consequence of this. So again, the Morelli trial was pivotal in showing a lot of things. So first is the feasibility of heart rate control in septic patients, and this was nicely demonstrated by the decrease in control in heart rate relatively rapidly after infusion of the beta blocker esmolol in that condition. Also, the preservation of mean arterial pressure together with some preservation of cardiac index and stroke index in that trial. So basically, the hemodynamics seems to be relatively well preserved in that trial. And this was a little bit unexpected, but was quietly well perceived, of course, by the community. Another very interesting study, a little bit different, because it was not really decreasing sinus tachycardia, but more looking at tachyarrhythmia, which of course includes supraventricular arrhythmias there in Japan with landiolol here, and was observed is a control of the heart rate more rapidly with the landiolol compared to the control situation, and again preservation of the hemodynamics looked here only by looking at blood pressure. So this is quite good, but we need to look into details and to look whether we have or not some adverse signals. Well, we have to be careful because indeed in the Japanese trial, we can see that 12% had some adverse event leading to study drug discontinuation. So 1 every 10 patients in that trial were indeed stopped. For the other, globally, there were the same adverse effects. But if you look at the details of the other, well, the rate of constipation was exactly identical in both groups. Well, this is not really what I expect as a major complication. So what are the major complications? Perhaps hypotension? Well, maybe not only, because here we can see that these are really more troublesome because we have indeed serious adverse events, which were blood pressure decreases in 3, cardiac arrest in 1 patient. Well, cardiac arrest is really a serious adverse event. I understand that study drug was discontinued when there was cardiac arrest, but okay, patient was dead. So this is something unexpected, and perhaps one of the things we need to think at later on is how to try to prevent this to occur. Also, if we look in more detail in the Morelli trial, we were indeed thinking that there was some beneficial effect, stroke volume was preserved, but oxygen delivery was markedly decreased and significantly decreased in that group. I'll say, okay, but oxygenation was preserved. Yes, but if we look at the lactate was not really improved there, while it decreased in the control group. So perhaps there are some signals that we need again to think at. But again, this is for the global population, where indeed, again, we need perhaps to look at more detail in some specific patients. The Morelli group published later on a series of patients where all patients received indeed the esmolol, and what they observed is that the cardiac output was more or less preserved, no significant difference. At least stroke volume was preserved there. Again, significant decrease in heart rate. But interestingly, they ascribed the beneficial effect to the decrease in arterial elastance, as was described by Vasilis. But one of the important aspects there is to remember that because ejection fraction was totally stable here, despite the fact that there was a decrease in contractility assessed here by DPDT, well, this implies that end-diastolic volume should have increased. Well, is it good? Is it bad? We don't know. I mean, it can be, of course, because there is more diastolic time to fill up the ventricle, and this is a good aspect. It can also be due to the impairment in contractile function and some dilation of the left ventricle. And this is, of course, not that good. So we need to know a little bit more on what occurred to this patient and to have more details there. Another trial was quite interesting by Bruno Levy, a small-sized trial, but they tried to look at several aspects, including the hemodynamics into details with some echocardiographic features. And was observed in that it was a decrease in ejection fraction and a decrease in many aspects evaluating systolic force, including the S-wave of the mitral annulus in tissue Doppler, including also the TAPSE for the right ventricle. They also observed some dilation with increase in end-diastolic volume and increase in filling pressures in these patients. So if we look again in the series of Morelli, they published in a subsequent paper in BGA 2 years ago, is that there were two groups of patients there. 23 patients had a high and preserved DPDT after esmolol, and some had a decrease in DPDT, a significant decrease in DPDT after esmolol. And interestingly, what we can see is that beyond all the variables that were measured there were no major difference to begin with in terms of norepinephrine doses, maybe a trend here in DPDT, but not really marked there. And what was really frightening in my mind is to realize that in the group with preserved DPDT after esmolol, the good thing is that cardiac output was not only decreased, but even increased, because indeed the diastolic time allowed this heart to be better filled. However, there was a very dramatic decrease in cardiac output in the other patients with decrease in contractile force after esmolol, where indeed cardiac output decreased from 5 liters to 4.4. And in these patients also blood pressure was more significantly decreased also. If we look at what were these patients exactly, well, these patients were patients where they excluded with a low cardiac index, valvular dysfunction, no more than this. But so despite the fact that patients with low cardiac index were excluded, 50% of these patients finally did not tolerate the introduction of beta blockers. Is it dramatic or not? It can lead indeed to some decrease in cardiac output, as also shown here by this study by Bruno Levy. And we say, okay, at the end, it doesn't matter because mortality, as shown in meta-analysis and so on, seems to be improved. That's true, but again, pay attention to some other data in some other situation. And remember that in acute myocardial infarction, when cardiologists introduced beta blockers when the patient was still in shock, what they observed was a decreased survival rate with beta blockers compared to the patient not receiving beta blockers. So indeed, this practice of introducing early beta blockers in patients who perhaps benefit more from preservation of their heart, the patient in cardiac shock with acute myocardial infarction, this patient really did not benefit from the introduction of beta blockers too early on. So perhaps when we discuss the unexpected side effects, we should perhaps also think at selecting the right agent. And indeed, having a short-acting beta blocker is, in my mind, crucial because it allows at least to stop when you see something wrong occurring in these patients. A debate, and we'll leave this for discussion after, is beta selectivity or some associated beta-2 effect for the inflammatory effect. We may discuss beta-2, but we need to discuss this later on. And perhaps when we discuss the unexpected or the expected side effects of beta blockers, well, the selection of patients who benefit most is probably crucial. Morelli developed this aspect of looking at the different waveform, arterial waveform, to detect patients tolerating and not tolerating. And so these patients with stable DPDT after esmolol had indeed some improvement in the diastolic notch pressure, while the patient who decreased their DPDT have really no improvements there. The issue is that it is afterwards. You give it, you look at 4 hours what occurs. So indeed, it is not really a way to predict what occurs. It's a way to say, yes, this patient tolerated, this patient did not tolerate. So what should we do before administration of beta blockers to try to identify? We do not have a lot of data for this, but just think again at what are exactly the patient in septic shock. When you look at a patient with septic shock, you have several clusters. You have some patient with diastolic dysfunction. This patient may indeed benefit from it to some extent, perhaps. Patient with right ventricular failure, probably not. Patient who are still hypovolemic, well, give volume first and reassess is probably a good thing there. Acute cor pulmonale in RDS in septic shock is really quite important. Again, we need to pay attention to this. And remember that left heart dysfunction can be severe. And sometimes this patient may require ECMO to survive. And again, these patients were severe. And if you look at the mortality, well, these are really unexpected high survival for patients receiving ECMO. But perhaps the most important aspect is to realize that it benefits mostly in patients with very low ejection fraction. So again, these patients with very low ejection fraction should probably not benefit from beta blockers. That's a good sense, but we do not have a lot of data. So look again back at these data already shown, and these are really very important ones because indeed we have these kind of patients, impaired ejection fraction, but still preserve cardiac index. Well, we should think that these patients perhaps may benefit from beta blockers. We do not know because indeed cardiac index is preserved, so these patients maybe they can benefit. These patients here, well, it's more complicated. If it is, these patients may receive some benefit from beta blockers because they could have more diastolic time to fill up their ventricle. Yes, maybe. Here, of course, we have the patients with impaired cardiac function and low cardiac index. No way, these patients should not receive beta blockers. And these patients here may also perhaps benefit because high cardiac index, high ejection fraction. So again, these patients may benefit from beta blockers. And if we look at the patient probably benefiting most, the patient with hyperkinetic function, yes. Patient well resuscitated, probably yes also. And we need to be more careful in the other way, of course. And a very good group, of course, as already mentioned, is a patient with left ventricular flow tract obstruction. But remember again that these patients benefit first for being better fluid resuscitated. So this is just when this pattern persists despite fluid resuscitation in these patients. So how to evaluate the cardiac function? We have several indices, and perhaps the ejection fraction is not the best. Because if you look at the different indices, you realize that depending on heart rate, you can go very high with heart rate before having really a drop in ejection fraction. While some other indices of systolic function, like the LV strain, may really decrease much more rapidly when we have some tachycardia. So perhaps detecting these patients more rapidly with some more advanced features may be more efficient. And to know who tolerates and not, we do not have a lot of data. This is a small size trial from China, and they looked at patients who increased stroke volume after beta blockers and not increasing stroke volume. And you can see that initially nothing separates these patients based even on the norepinephrine dosage or whatever. But if you look at the MAPC, so the displacement of the mitral annulus, which is basically also reflecting the left ventricular strain, well, these patients, when they have a low MAPC, these patients decrease stroke volume. When they have a high MAPC or normal MAPC, these patients here have indeed a preservation of cardiac output and stroke volume. So this may be a way to select the patient who best benefit from beta blockers in these conditions. So some patients may experience some undesired effects. Selection of the patient is really crucial. And we have to remember that even after excluding patients with low cardiac output, up to 1/2 of the patient do not tolerate the introduction of beta blockers. So echocardiography is really interesting there to try to identify the patient who may not tolerate and the patient who may benefit from beta blockers. And of course, always use short-acting beta blockers because you can stop when you observe undesired effects. And with this, I thank you for your attention.
Lovely. Daniel, thank you very much indeed. Again, lovely talk. Right, what we'll do, please, lots of questions are coming in. Please write your questions on the eLives TV chat, and we'll try and get through as many as we can in the next few minutes. So if, yeah, and let me just, sorry, I'm just sorting out my, my computer. Right, okay. I suppose a lot of the questions have actually been asking, when do you start a beta blocker? You know, obviously, you know, Daniel's given a nice exposition on the use of echo, but clearly you often need a good person who's experienced with echo to look at MAPC and so forth. But at what point in a patient's journey, as it were, they've come in with septic shock, you've obviously stabilized them first, but when do you think you should start? How do you titrate carefully and to what end point? So a lot of the questions surround those three questions. So Vasilios, should we start with you and then Daniel?
Yeah, theoretically, as the ESMO sepsis trial has showed, if we start too early, maybe earlier than 24 hours, then this would be a destructive alternative. Theoretically, we have to somehow evaluate volume status and be certain that there is no volume depletion in our patients. Nevertheless, I think most of our septic patients are volume overloaded and not volume depleted. So I think volume status will not be a problem when we decide to start beta blockers in patients with beta blocker with tachycardia that does not respond to any kind of re-challenge. Secondly, unfortunately, doesn't anybody is expert on using cardiac echocardiography. We think that echocardiography would be our stethoscope in every kind of patient when we're trying to evaluate surrogate markers, left ventricular contractility or pulmonary vascular resistance in patients with ARDS. But I would like to just discuss a kind of theory I was reading about for this talk, and it concerns the diastolic shock index. I was really impressed by this study that was published a few years earlier. It was from Jean-Louis Debulle group, who showed that patients who had an increased diastolic shock index, which is actually the ratio between heart rate and diastolic blood pressure, upon administration of vasopressors had the worst outcome. Maybe the pattern of the arterial waveform in patients with heart rate might be if the patient, for instance, has high diastolic pressure in relation with high heart rate. That's okay. If the diastolic pressure is low, this means that there's a huge vasoparalysis. And maybe in this kind of patients, beta blockers would have much more, I don't know, indication. Maybe we should try them based on this kind of different patterns of the arteriogram. I don't know. But in general, the state of vasoparalysis and contractility should be guide us to achieve an increase in stroke volume simultaneously with increased heart rate.
Daniel.
Well, I would add that fever control prior to administering beta blocker is probably something important. I mean, if you have a patient, you want to decrease heart rate, but if your patient has a 39 degrees, well, it's not a good time to initiate beta blockers. First, try to cool a little bit down to not to cool, to normalize the temperature and not to keep the patient with such high temperature. This is back to the data from Frédéric Schorgen and Laurent Brochard a few years ago, but when they also showed that this may be helpful to gain some hemodynamic stability there, and you will gain exactly the same aspect on heart rate control in these conditions. Regarding the echo, I think I made the case, and I think that without echo, I think it will be dangerous to initiate beta blockers because the other patterns may be misleading. And I think that the latest data from Morelli's group looking at their series published in BGA, they nicely shows that unfortunately at baseline, the morphology of the arterial waveform was identical in the patient tolerating and not tolerating beta blockers. The good thing is that the patient tolerating beta blockers had an improvement in their arterial waveform. So again, touching on what you mentioned on the reflection of waves and the probably improvement in arterial elastance and many other factors that can be improved by the beta blockers. The problem is that if you just look at the arterial waveform, you can be again misled and have some patients who will not tolerate it. So it's a little bit difficult to predict who will benefit or not just based on the usual simple hemodynamic features that we can have at the bedside.
Okay, let me pin down one. There's a question about do you use heart rate, a high cardiac frequency, as the cornerstone for initiating treatment? So what criteria? You've got a patient in shock, they're on norepinephrine. Do you say, well, if their heart rate's 90, would you use a beta blocker, or does it have to be over 100? Do you have a strong view as to, apart from, using echo to try and select patients, but do you think heart rate is the best indicator? Vasilios first.
Well, we think to to understand that circulation is a very complex phenomenon. Okay, so we have to integrate a lot of parameters, in my view. We just can't rely on the value of heart rate, on blood pressure. We have to understand how different parts of circulation, venous return, left ventricular ejection, contractility, vascular tone are interrelated. So I will not give beta blockers that easily in a patient upon admission to the ICU. I will try to be more or less certain, because I can never be certain 100% about his volume responsiveness. And if the patient is not volume responsive, for instance, due to diastolic dysfunction or for other reasons, then I will try to evaluate the effect of beta blockers upon stroke volume. And if there is a parallel increase in stroke volume, maybe I say, I could continue titrating my beta blockers towards a heart rate less than 95 beats per minute.
And Daniel, do you have a view?
I have more mixed feelings about this. I mean, I think that tachycardia is the entry for considering beta blockers in this situation. However, we need to be cautious with the target. It has been, let's say, usually set around 90 by the study by Morelli and others. But at this stage, we have to admit that we do not know exactly what is the best target. Maybe if we decrease from 115 to 105 would be already enough, and perhaps in some patients we are going too far or not enough, perhaps in some others, or by just trying to be at 90. So I think that we need more data to know exactly what would be the best heart rate. What puzzles me a little bit when we discuss all these factors is that when we look at the data from the Carl Verdun group that were published in Shock Hour, if I remember correctly, and when they just control heart rate by another agent, which was ivabradine, well, there was no beneficial effects there. So the heart rate itself is used as titration, but it's probably something more than just controlling the heart rate that should be considered. And I have to admit, I'm humble here. I do not know exactly what would be the best target and trigger for this use of beta blockers in these conditions.
Yeah, in fact, somebody's just come in with a question challenging the need to control heart rate in the first instance. So I suppose a bit like, you know, controlling temperature. Is this a natural response? Why should we interfere? You know, so again, good philosophical question.
This is called the logical fallacy. It's a kind of logical fallacy, normalization fallacy, actually. We are educated to try to have normal values everywhere, even though sometimes these normal values is an adaptive and not a maladaptive mechanism. But since we don't understand the complexity of physiology and we are stuck with normal values, maybe we don't know what is the best solution for our patients. So I don't think that heart rate per se means anything, you know, high than 90, low than 90. We have to understand that it's a complex interplay of different mechanisms. So we have to take into account different mechanisms responsible for the cardiac output, because what are we trying? We're trying to achieve the best oxygen delivery to our tissues, okay? And when we have an hyperadrenergic state, meaning a lot of oxygen consumption, cardiac output by definition will try to meet this kind of metabolic needs. When we have, for instance, a lot of inflammation within the tissues, stress will respond, sympathetic system will be activated, even though there's not a kind of hemodynamic issues. So there are many, many different mechanisms that could actually turn on the sympathetic nervous system. And so we have to be certain that our patient is not volume depleted. And I think nobody treats a patient, septic patient, who is volume depleted. I think the problem is volume overload and not volume depletion. We should think about analgesia, about sedation, about mechanical ventilation, about intrapulmonary pressures, which can also affect venous return and subsequent heart rate, and then decide, or at least try and error maybe, to check, to test the effect of reducing heart rate upon stroke volume.
I've got, in fact, one quick comment from me. I would agree. I think, to my mind, heart rate is a good surrogate of stress in general, rather than just a pure cardiac marker. We've got 5 minutes left and quite a few questions. So short answers, please, gentlemen. Is there a role for oral? A few people have asked about oral beta blockers, bisoprolol, other. Do you think there is a role in these patients? Or would you just go for short-acting IV? Daniel?
Well, I don't think there is a role in the acute setting for these oral beta blockers. It's too difficult to really use doses that can be really reach the good average of the heart rate, and so it's too easy to go too far away in making this patient too bradycardic and so on. So I think it's not the safest way. So yes, for stable septic patient without shock, but not for the patient in shock.
Yeah, unless you've got something to disagree with, Vasilis, there, I've got other questions I want to throw at people. What about patients with aortic stenosis, sepsis? The writer here said he had such a patient on a high dose of noradrenaline with aortic stenosis, and it could be decreased quickly after beta blockade. So do you have a view? Because, I know vasodilators can be used, albeit you've got to be careful. Do you have a view, either of you?
No, I think these patients are very atypical, and so everything you do can be very dangerous. A few things can be beneficial, but we have to be very, very cautious with these kind of patients that can decompensate very rapidly.
And Vasilis, do you have a comment on those sorts of tricky patients?
I agree 100%, but I think that we need to consider input from difficult specialties as well. I think I'm not a cardiologist, so in this case, I would need the consultation of a more expert than me in echocardiography to evaluate the pressure gradients and all the potential impact of beta blockers on this kind of patients. But what we see in our unit is not that common, patients with severe aortic valve stenosis.
Right.
It's not that common.
What about the patient, quickly, gentlemen, with right heart failure, right heart dysfunction? Do you think there's a role for beta blockers? Do you think you might improve diastolic function, and therefore allow that right ventricle to contract and maybe reduce pulmonary pressures as well? Do you think there's a role there?
Well, I'm really more afraid on the use of beta blockers in this population, because often heart rate is really a good way to try to minimize the load of the right ventricle. And so after cardiac transplantation and so on, we know that the ideal heart rate is between 100 and 110 just after cardiac transplantation for the right ventricle. So I would be much more reluctant to try to decrease heart rate in patients with a right heart dysfunction than in patients with left heart dysfunction.
Right. I'll give one to Vasilis. Interesting question. I don't know if there's a right answer, but how does the lung and lung perfusion respond to beta blockers? The person's asking, they're thinking about antibiotic penetration into a patient with pneumonia. So will you affect flow, and would that therefore potentially affect perfusion and antibiotics?
Can you repeat the question? I think I didn't understand exactly.
It was, how will lung perfusion be positively or negatively affected by beta blockade? And the person's asking in terms of antibiotic delivery to an area of pneumonia. It's a philosophical question.
Yeah. I think the most important issue is end-diastolic left ventricular pressure. So if left ventricular end-diastolic pressure is increased, this could induce a pulmonary congestion, and this will increase pulmonary vascular resistance and right ventricle. So I think in cases, I don't think the problem is the administration of antibiotics within the lung. It's not actually that important in terms of cardiac output. The most important issue here is patients with pre-existing or not pre-existing diastolic dysfunction. Because as Daniel has already said, beta blockers can ameliorate diastolic dysfunction, particularly in septic patients without any pre-existing history of diastolic dysfunction. But in some patients with history of diastolic dysfunction, coronary artery disease, hypertension, the reduction in heart rate will increase even further in diastolic pressure. And this will increase pulmonary congestion. In this case, the potential effects of antibiotics, I don't know what exactly our viewer meant, will not have the minimum inhibitory concentration at the level of the alveoli, if I understand the question.
Yeah.
So may I just add something on this?
10 seconds.
Yes. In 5 seconds, beta blockers improve the shunt. We know this from a long period of time, that beta mimetics increase the shunt in the circulation, and while beta blockers can improve this. This was a paper from Johnny Vincent in last century.
John Burke as well, the theory of Burke for the DQ inequalities.
On that note, gentlemen, we're 1 minute over time, but thank you for a fascinating hour. I've really enjoyed it, and I hope everyone listening in enjoyed it too. And thank you very much indeed, and have a lovely afternoon, or wherever you are in the world, morning, evening, whatever. Thank you for coming.
Thank you very much.
Bye-bye.
Bye-bye.